to the Marta Grand Rounds. We have commenced Marta Grand Rounds some time ago, but it's good to have it on a virtual platform. It seems to be very popular with attendees and speakers alike. Today's speaker is Dr. Rowena Mobbs. She's a neurologist, and she works here in North Sydney in her private rooms. And Rowena has a specialist interest in head injuries and concussion in particular, and she's the clinical director for the Australian Sports Brain Bank, which I'm sure she'll give a little bit more information about. So she likes to do some research into chronic traumatic encephalopathy, and she also has a very active interest in cognitive impairment and dementia, and she offers a very holistic practice with respect to that, as well as other neurologic conditions. So her talk today will be about from headache to chronic to head injuries, and assessing the patients with repetitive head injuries. With this particular forum, if you have some questions, please put them into the Q&A at the bottom of the screen or the side of the screen, and then that can be answered most likely at the end of the talk. The chat function I'll keep an eye on, and we can use that as well, but the Q&A is probably the better option to do that. And then Rowena will be able to answer those questions at the end, so there won't be any sort of interaction during the talk. So without further ado, Rowena, welcome, and we look forward to hearing your talk.
Thank you so much, Raoul. It's fantastic to be with you this morning. Nice and early. I hope you've had a coffee already. It's been a long week for us, and we'll go into some of the activity and media around this topic. So I'd like to expand on headache, because that's one of my passions in general, but it really pairs intrinsically with cognitive impairment. And now this issue of chronic traumatic encephalopathy, or CTE, of which we're still deciphering. There's a bit of controversy in this area internationally about what tauopathies mean as far as CTE, and do we have similar syndromes to what the Americans are finding in gridiron players here. So it's really exciting, burgeoning area, and as always, we're sticking to what the science will tell us. So let's go through some assessment from the coalface of the patient with repetitive head trauma, and give a bit of background for your awareness, and I hope it's very useful going forward. So I always start with this slide in my talks, really. It's this is Bondi, circa 1900. The life expectancy at this time was very different, of course. So for women, it was 51, for men, it was 47. So extraordinary, really. Dementia was very rare, and certainly this was just at the time when Alois Alzheimer was discovering Alzheimer's disease and reporting it, but it wasn't really widely known or understood, really. So things are very different, and for that generation, you know, they had famine and war and infections, and here we are with COVID now, but of course, you know, the flu pandemic around that time too. So as our life expectancy has increased, and this is very much occurring in the developing world as much as here in Australia as well, we've got age-related dementia. So it's taking over, it's already taken over for women as the #1 cause of mortality in Australia. Shortly, that will be joined by the male population. So once you reach 70-ish, you're starting to see a significant increase in your dementia risk, and it goes up and up. By the time you're in your mid-80s, you know, a fifth of people will have a degree of Alzheimer's or a degree of other types of dementia, being the umbrella term, of course. This is work of my sister, Virginia Newcomb, over in Cambridge. So she's a professor of neurointensive care. So she's working with David Menon's group with really interesting work into TBI, which is a big topic as far as overall dementia also. So she's looking at tractography changes, and you know, this is more severe head injury, but they are looking at the mild concussion spectrum and determining that, yes, there are probably rather longer lasting inflammatory changes or tract changes than we thought. So a concussion is no longer just a concussion. This field is rapidly moving on, and she's looking at issues like consciousness and awareness and outcomes as far as brain injury, trying to predict that. So very exciting work. And there's some collaboration here too, of course. So here's the beautiful images of the tracks of the brain. So where are we at in 2020? Well, of course, very different to Bondi 1900. So we've got the fabulous emergence of elite sportswomen, and then across all the grades and through to the grassroots now. So 5 and 6 year old girls are starting to play football. So it's fabulous to see that change and towards equality. Of course, not there yet. But what does this mean? You know, there's a lot of body of work emerging around female concussion as having more severe, more prolonged symptoms. And then, you know, this might be anatomical. They're holding up a relatively bigger head to the neck ratio. There's, you know, other biomechanical factors, but there's a whole field of neurohormonal changes now in the research and clinically, of course, migraine is really much more common in women. There's that overlap, and as I'll go on to explain, that's a big overlap in traumatic brain injury as a whole. So let me allow to show this video just to sort of highlight what we're talking about.
Passes on now for the control of Horton, gave it back up to Lucic, and a shot. It's blocked aside and down on the ice now. It's Horton.
This one's a whole lot of nasty. Aaron Rome comes up and just delivers a crushing open ice hit. Nathan Horton is in some serious trouble right now.
Okay, so that player who got concussed, you know, knocked out, sure. That's not really an indication, we think, of severity of injury, by the way. The brain is stunned, it either, you know, it can be knocked out or not, it can have convulsions or not, as this player is demonstrating, and a degree of the deep breathing, that's a spectrum of convulsion, epileptic activity, and dysautonomia at the time. So a very stunned brain. So I am stunned when players return to the field. But nonetheless, there seems to have been this even very recent determination that people should play. I'm always very strong to emphasize that how much I love sport, and I'm not going to say we shouldn't be playing this sport, but as you would expect in a very reasonable society, people should understand their risk. So this attitude of Eels coach Brad Arthur said, Matto's all right, he'll be right. We'll give him a good 10-day break and he'll be right for next week. I mean, do any of us, are any of us brave in our clinical practice to be so predictive? I would dare say not. And then yesterday, and the day before, sorry, so Wednesday night, big fuss, State of Origin, Boyd Cordner, the captain of the Blues and the Australian team. So he's had now, I think, 4 concussions in recent times, and each one seems to be a little easier to sustain. And if you look at the footage, it seems like perhaps his opposition knew that and sort of almost stuck the elbow out, and he went down. So, but the unfortunate thing was he was still stumbling and clearly concussed, as the initial video footage clearly shows, but he went back on at 10 minutes. So that wasn't too well received by people like Peter Fitzsimons and others in the media. So here we are. So if you're bored at night, if you're over Trump, this is some good reading by Fitzy, who's really supportive of our work. This has been going for 3 years now at the Australian Sports Brain Bank. We haven't had any funding to date. We've been all contributing voluntary time to get the pilot data up and running. We've published CTE cases across AFL, Rugby League and Rugby Union. There's 15 brains in total, about half of which have CTE. There's nearing 500 pledges to donate brains to the Australian Sports Brain Bank. So we're very overwhelmed and welcoming and of this work, and honoured to be part of it. It's been, to be honest, a little closed door as far as progressing the work from the sports, as you would expect. There's not a lot of encouragement to be doing this work, let alone funding. So next week we're holding a big seminar actually with leadership across government, insurance and medicine and research, calling for funding, calling for collaboration, and recognising that it's not just about league or union. This is a much wider issue, as I will allude to. The Kiwis are beating us, so here's some motivation. They already have the advantage, though, of a government-based insurance system for concussions. So anyone can be seen in one of the free concussion clinics, attend, see a neurologist, see a neuropsychologist. And then, albeit there might be a fairly basic registry of data, nonetheless, they're obtaining longitudinal data. And their own government recently provided $8 million towards this sort of effort. And I attended this launch of the New Zealand Sports Brain Bank in December last year. So it's just wonderful to see, and the All Blacks are very supportive. As you might have already been able to tell, I'm not sure, I'm a big fan of sports. I grew up in Canberra, which was neutral territory as far as all the football codes. When I grew up, I didn't have there was no opportunity for women to play football, at least where I was. So I'm kind of pleased for that now, of course. But, I love my sport. I used to watch sport every weekend, and I did end up going on to represent Australia in fencing and modern pentathlon. So I certainly understand a little of what players are going through. And unfortunately, we lost the grand final last year, big Raiders fan, but there's always next season. My dad, so it's a bit of a mixed history. I grew up with a father who's a neurosurgeon. In 93, 94, he was leading the NHMRC protocols into concussion in football and boxing. That was approaching the Sydney Olympics. And again, there was kind of big brother pressure not to really talk about this, because boxing was going, is of course part of the Olympics. But there was call for, after a 12-month body of work, a central fund for research into the prevention and management of head and neck injuries, particularly a uniform approach to concussion. We're still not there. And so this is my other part of the reason why I'm pursuing this work. I've had it in my head for a long time. I'm very passionate that Australia should be leading this work and getting there. And then after I've entered this field in neurology and become a cognitive neurologist, my own mother developed Alzheimer's disease, admittedly unrelated to head trauma, but I was able to really empathize with the marathon of dementia diagnosis, dementia care, and then the grief and loss with palliation and eventual death. Now, let's turn to a little of the practicalities. So at the coalface here. Let's go back to concussion for a minute. So the first hours, of course, are critical. I would say the first minutes are critical. Players should not be put in a position where they can be concussed again and have a even more severe head injury. They're not able to judge for themselves. They have a loss of insight. They're not able to coordinate well. So they're at a higher risk of putting their heads in the wrong position. And it's just wrong. So I think our concussion protocols are not strong enough. The first 24 hours, of course, we are looking for things like extradural hematomas. So CT is useful, and there's some emerging technology out of the US looking at ultrasound for this, particularly in the military population. So that may come on board at some time. MRI, I generally, as a rule, like to take that over CT. It's more detailed, it doesn't have radiation. We don't really want our young players having CT after CT for concussion. What I emphasize is the follow-up and obtaining point of care and rapport is critical. To do this, you have to enlist carers, i.e. the family or friends, and get that player back for review, because at the 1, 2, 4, 6 week mark, the symptoms can emerge in a very much a delayed fashion. There's a good, reasoned emphasis on some time off, relaxation, and a graded approach to play. I think that's one of the areas we've been doing relatively well in. It's sort of symptom managed, but then my good colleague down in Victoria, Alan Pearce, is finding, using transcranial magnetic stimulation, it's too early on a Saturday, that there are some cortical changes in the motor tracts and right up to the cortex. So players are not physiologically normal after concussion, even though they be symptomatically normal. Simple analgesia is the best initial approach. We should be avoiding opioids and other sedating pain medication if possible. No alcohol, no driving. This is strict, this is tough. We don't want further complications, further risk of head injury, further risk to the community, of course, driving. And alcohol is just never good for the brain at this time. Education is probably one of the major things we can do. So it's astounding that, up to 30% of players don't don't really realise and recognise about their concussion, or have they had a concussion, or really what concussion is. Of course, that's improving with this sort of recent media. But there's every role for these consultations to be educative and prevent the next concussion or manage it well. Enlisting care, as I've talked about, that's a role in neurology, of course, in general, getting the collateral history. If you want to go to the literature, there are some very good AMA and AIS guidelines released a couple of years ago, but they were really light on, if not contradictory to any literature for CTE. You know, whether or not the science is screaming at us that it's here, I think that it needs to be looked at. And so we need to consider that, even in our guidelines, a cautious approach where there could be head injury and lifelong impairment. When to refer? So I get asked this question a lot. When on earth should I refer to a neurologist? And of course, you know, I, like all of my colleagues, we're very happy to see patients at any time with any concern, because the nervous system, you know, it's always very concerning. People are worried. They're worried about their brains, which is a good thing in lots of ways. But when to refer? When insight is lost. So across the head injury spectrum, doesn't matter if it's concussion, post-concussion, questions of CTE or traumatic encephalopathy syndrome, or if they've had a more frank, moderate TBI, if they haven't got insight, you can pretty much be sure there's some form of definite cognitive impairment. I also ask people to refer at the earliest concern over memory, cognition, or behaviour. What we're seeing much more in the literature is an expansion to emotional cognition and behavioural cognition as key elements to assessing a patient. Now, that concern may be from their patient, but also their carer, of course, with that loss of insight. So listen well to what the families say. I would never assess, if possible, if the patient's willing for me to talk to family, I will never assess them alone. I will be on the phone to the family, or I'll try and get them in. When to refer? When there is mood mixed with memory. So the intrinsic nature of cerebral disease is that the neurotransmitter pathways are changing. So there's shifts in serotonin, etc. So whenever you have a primary cerebral condition, you almost intrinsically there's a developing anxiety or low mood or irritability or frustration or some sort of mood disturbance. Not only due to adjusting to the injury, but the neurobiological changes. Anyone at risk of CTE. Now, how long is a piece of string? I don't know. Some of the American literature is saying that it might be 2 years. 2 years of head exposure, repeated head trauma exposure, you're at risk of CTE. That sounds a little short, maybe. You know, in my cohorts, I'm seeing patients who are 10 years or more. I think the latest is, you know, we've got no less than 13 years repeated head trauma exposure. But many people are starting at the age of under 9s. They're going through for at least 10 years through their school years. I do have patients in their late 20s who I am worried about, who seem to show traumatic encephalopathy syndrome. And certainly the body of our work is in 40s and 50s, 50-year-old patients. So these are young patients who are presenting like 70-year-olds. So this is a warning I'm throwing out there. We got to look at the numbers, but it's concerning. Anytime there's complex concussion, if you're just getting a feeling that it's not going well, we're not garnering improvement in the initial days or weeks, so it's be really good to see them in neurology. What do we do? Well, you know, it can be seemingly simple things, but cognitive neurologists, we're very calibrated to assessing our patients and seeing all types of cognitive impairment and all types of dementia, and then mimics and overlaps, like migraine, like depression, like autoimmune encephalitis, for example. Okay, so here we look at the, you know, just drawing a cube or drawing a clock face, and you can see how well this very intelligent, very normal patient has done on the left. There's a little bit of impairment in the middle, and then we are seeing this sort of thing in repeat head trauma. So what does it mean? All right, so I'll just show you a little video here of what, again, observing closely, how are they holding the pen? How are they forming the words here? So this is a patient with Parkinson's plus disorder. So very slow. That's almost what you call macrographia. So there may be some emerging frontal elements. but certainly very slowed movements. And then I like to use the ACE3 Australian version as my screener. I don't do many mental. It's too brief for me, but you know, reasoned within the literature. I think if you had to pick a short test, you'd probably be looking at the Montreal Cognitive Assessment, the MOCA, as a choice, particularly, as I say, with the emergence of the new age of behavioural and emotional cognition. It tests that a little better. All right, so who's going to experience TBI? Well, all of us, potentially, right from the young age. So I have seen patients with a history of fall from the age of 1 who turn out to have had, you know, frank TBI or neck injuries. Of course, our elderly patients with their falls. We've got people going to Bunnings every weekend. I'm one of them. And then we've got the very sad and sorry state of domestic family gender-based violence in this country. There's a lot of activity, possibly, you know, we're all striving for more coordinated activity in that space. And then, you know, we haven't even got to the real stage of managing TBI in these patients, let alone understanding risk for CTE. So we are having women involved in our research. We've already had a couple of cases of domestic violence who are patients who are being studied. WorkSafe. Okay, so there's been some emphasis on this of late, of course. These are the sorts of mechanisms, you know, collapsing structures we've seen, or, you know, often I see patients with steel coming down on top of their heads from unloading the truck, that sort of thing. Then there's the jockeys. Okay, so there's other sport outside of footy. I know it's hard to believe, but there are other sports. So of course there's horse racing, there's ice hockey, there's snow sports, there's even there's some literature in diving, you know, high platform diving with repeat hitting the water. So there's a whole range. Then there's defense patients, military, so the blast patients. So I see patients who've had over 1,000 blast injuries up really close, like 2 or 4 meters. Beware, of course, the PTSD overlaps, and we will study that well. The blind patients, so they often fall frequently. The frail patient, of course, epileptic, alcohol use disorder, Parkinsonian patients, and then REM sleep behavior disorder I put there because that can be severe where a patient's falling out of bed quite often, or, you know, that maybe there's an element of head trauma there. And of course, those patients often end up with Parkinsonian disorders or have an overlap with that. So Parkinson's disease or Lewy body disease. Right, so we've started the SNAP CTE study. It's over at Macquarie University. We've got, so there's symptomatology, neurocognitive and pathophysiological changes in CTE. So this is our equivalent, and we are collaborating with the Boston protocols, the Boston work into NFL. Statistically, we're aiming for 1,300 participants to understand our risk here in this country. That is going to be expensive, and so we're calling on funding for this. There's an initiative called Mission TBI from the government, of which we're very thankful and looking forward to opportunities to partake in that. This will be a 5 but extending to 10-year study. We're studying patients every 2 years, looking at neurology, neuropsychology and biomarkers. And this will be linked to the Australian Sports Brain Bank to really get the gold standard neuropathology and understand what type or types of dementia they have. These are our sort of typical demographics. I mentioned people in their 50s, mean age 53. We do have mostly men at this time. We're finding, I'll put this out there, we're finding that our players in league and union and other sports are very intelligent. So I believe there's a particular type of sporting intelligence, as you would think intuitively. And so they're not all drunk, they're not at a low baseline, you know, they're in an intelligent group. Probably about half of our cohort is having a background of binge drinking. Some have alcohol use disorder mixed in with that, but often it seems to be that they are, from what they are telling us, that they are self-medicating symptoms. So they are developing mood, cognitive behavioural disturbance, and then drinking. Here's the mixture of sports. So we've got rugby league, union, NFL, footy and soccer, boxing, big time. So these boxers, they do seem to be Parkinsonian. So there is a sort of a spectrum of severity emerging within our cohorts. We've got equestrian, BMX riding and so on. So these are unpublished. That is our big caveat. We're just submitting this week to Frontiers in Neurology. They're doing a special program on CTE. So we expect that these will likely be published. So, but this is not yet peer reviewed. So here's our ages and the characteristics of the patients. I'm using the ACE screen, so we are finding, it seems that though there is a strong association of insight to cognitive impairment, so hence, that's the first thing I really, other than looking at my patient walk through the door and looking at their social interaction with their loved ones, I'm always starting off, and I assess who they are, what job they're doing and so on, but I'm starting my assessment with insight. So can they tell me about the problem, as you do? What's the problem? They're not really aware of the issue, they're fine, but they were encouraged to come in by their loved one, and then the loved one will tell me about the story. Impairment of insight, I'm concerned about primary cerebral neurodegenerative disease. And what is the results on the cognition? We're starting to see a particular type of memory deficit in these traumatic encephalopathy patients of encoding. So that's the kind of learning on the run memory. So you're having a conversation with someone, you're absorbing the information they're telling you, and you're prioritizing the importance of that information. So of course, if someone's telling you that, you know, they just lost their mother recently, you're attuned to that. But we're seeing these patients not learning those sorts of immediate memory tasks as well. Okay, so we're studying headache because I think it's important as well to clear out migraine from concussion, post-concussion and tests if you're going to understand their cognitive deficits well. Apart from managing the symptoms, and it's one way we can really help people. As neurologists, we're good at managing migraine. And it appears from our results that are listed here, that the treatment response is very, very similar to what you see in classic chronic migraine. So we're getting figures in the 80s, for example, responding to things like botulinum toxin therapy. We're just moving on to newer therapies like CGRP antagonists. So there is always hope, even if you do happen to have an emerging dementia. We like to manage symptoms, manage the whole patient, of course, treat any medical condition that we can. So let's look, let's take a break now and shift gears into some of the background around headache and concussion in general. This is a lovely paper a couple of years back looking at purely the biomechanical effects or mechanical effects of an impact of a concussion. So there seems to be like a bell ringing phenomenon, an oscillatory or vibratory effect throughout the brain. The natural history is that most people will recover over a week after concussion, but then, you know, those that develop post-concussion, which is an arbitrary sort of time frame, technically 2 weeks, but most sort of post-concussion phase is within the 7 to 10 day period. At 1 month, yeah, really the majority are improved, but then 10 or 15% can go on to have a true post-concussion syndrome. Now, more symptoms at initial presentation was associated with a higher risk of persisting, but the severity of symptoms does not necessarily correlate with the incidence of post-concussion syndrome. I find the post-concussion symptom scale pretty useful. I've got it listed here. The reason is a lot of the types of symptoms they're asking for, I mean, it's identical to migraine as well. And if you're over 13 on your score, you typically would have a more significant risk for post-concussion syndrome. So I might note that and just watch them like a hawk. So headache and concussion, the literature, of course, is variable from occurring to a quarter of patients up to 80% of patients. I mentioned that the headache prevalence, duration and severity is greater in those actually with mild compared to severe trauma. Pre-existing headaches are a risk factor as such, but not the whole story. And the results we're about to publish, we only have 2 patients out of our cohort of 47 who have a family history of migraine, which is, you know, kind of astounding when you think about the high prevalence of family history in true, you know, classic migraine sufferers. The onset of the headache, technically according to guidelines, is within 7 days of injury, but I have seen many patients with delayed headache occurring at 1, 2, 3 months down the track after concussion. The subtypes of headache in traumatic traumatic etiologies are similar to non-traumatic. So migraine and tension predominate. Tension the most frequent. But migraine, interestingly, was more common with that vibratory blast effect in military patients. There's a lot of overlap with other types of headache, more than one type. Here are some of the symptoms of migraine. So patients seem to believe that migraine is a severe headache requiring you to go to bed for 1 or 2 days in a dark room with vomiting. But of course, it's much more complex than that. Migraine is from tension headache right through across the spectrum to having one symptom like light sensitivity, or nausea or dizziness, or a combination of any of these listed symptoms. What I will say is that mental clouding and fatigue seem to be extraordinarily common. And you can tell they're very similar to concussion. So we just empirically treat for migraine. There's no other way to know, is it migraine complicating concussion, or is it post-traumatic syndrome, which is refractory to any management largely. When you do your MRI, you may even see these flecks of white matter changes of migraine within the brain. So these are non-significant clinically. We don't really understand them, they're non-specific, but perhaps there's a degree of inflammatory change at the time of migraine. Then other headache can occur. So TMJ dysfunction can occur, direct trauma or jarring, withdrawal pain, occipital neuralgia. So often patients, say manual labourers or fall from a ladder, they might hit the back of their head, or on the field, you know, a player gets a concussion with collision and then falls back from the force onto the ground and has a second concussion at the time. Now that can injure directly the occipital nerve. So I will always consider doing occipital nerve or perineural injection of steroid with our patients. And in fact, that has evidence in managing migraine, not just directly the trauma at the occipital nerve or irritation. Many of the, you know, those involved in trades will be wearing a helmet, and so that can further irritate it. People, when they develop migraine and neck pain, might go to one of the foam or memory pillows, which can irritate the occipital nerve. So it's a good one to think about managing, sending them off for an injection. Other headache, trigeminal nerve injury, very rare in my world, I suppose more common in the neurosurgeon's world. Dysesthesia is at the site of a scalp laceration and soft tissue injury that will usually recover steadily over weeks or months. Very rarely, again, a low pressure headache, a trauma leading to a dural root sleeve tear or cribriform plate fracture. So of course, if they've got rhinorrhea, that's new, you should consider, is it CSF rhinorrhea, and run it off for testing. Any other headaches? So cortical contusions can cause headache, I guess with a degree of subarachnoid hemorrhage rather than the brain substance itself. Traumatic dissection of carotid and vertebral arteries, we see that. So direct punches, or question, maybe chiropractics after their injuries. There are cluster headaches and other types of rarer forms of headaches with autonomic dysfunction, so severe tearfulness. And if you've got a patient who's just crying on one side and just holding their head, they've got a dysautonomia, most likely related to this thing called SUNT. So that would be a patient I'd really be keen to see in a neurology clinic. All right, so sleep. Sleep is very important, of course. So we look for PTSD after having head injuries. So it could be a car accident patient, but you know, it could be a military patient, of course, but maybe they had a fall from a ladder and you know, and they have PTSD resulting from that. Insomnia or hypersomnolence, conversely, is really common after concussion. So you know, and you'll find that fluctuates throughout their concussion or post-concussion syndrome. They have good days, bad days, good weeks, bad weeks. And so they can be surprised, you know, they think they're on the mend and then there's a bad week. I always look out for obstructive sleep apnea. The only way to know this is it's not through neck circumference or snoring or any other measure, it's to send them off to the sleep lab. Women may not snore, they may present atypically. And then I'm on the lookout for REM sleep behavior disorder. So while you're getting a sleep study, you could get a video sleep study. and look for those abnormal reenactment of dreams. So if they're a footy player, they're likely to be playing footy in their sleep and maybe kicking and hurting their partner inadvertently. Dizziness and headache is common. Dizziness actually seems to be one of the indicators of perhaps a severity in concussion. Non-specific headache dizziness can occur, that just sort of annoying, but it does affect people, disequilibrium. But it could go through to true vertigo, and it could be associated with tinnitus, which can be a migraine symptom. All right, so look at these patients closely for migraine management. Psychology and headache. So patients get irritable, they get anxious. It's like, parents say, I've lost my son, he's a different person. Even though these are relatively mild-ish symptoms and superficially they look good and they may even be back to work, they're just not the same after these sorts of injuries sometimes. People can be really intolerant of any cognitive overwhelm. And so we do encourage, in a rehabilitative approach, toning things down. So avoiding too much television, bright lights, noise, crowds. Never drinking. So people are more susceptible to alcohol, and we wouldn't, it's bad for the brain and they may fall and injure themselves. Okay, so perceived impaired memory and concentration is the most prominent immediate concern after injury, but then there's these subtle irritable changes, and in traumatic encephalopathy syndrome patients, so those at risk of CTE, we are seeing the irritability and the rage to a drop of a hat. So this is very concerning. These people often have young families, and there's rage and potential violence. And then, psychiatric diseases considered. I get asked, when do you see a neuropsychologist? So I work day to day with my neuropsychology team. So they're really good with diagnosis, evaluating prominent cognitive, but also psychological complaints. So they can tease out mood disorders for me. They can tease out functional cognitive impairment, so conversion disorder, a subconscious phenomenon where the patient's memory goes, or they're feeling a bit dissociated and not thinking straight. That can be functional. So that there can be a role of reassurance in neuropsychology, but there's also very tailored, individualized rehabilitative strategies from that assessment. So they might say they've got this planning deficit, so we need to help them, with sort of occupational therapy and structures around their cognitive planning. We need to enlist family to engage in them in this way, at this pace. Their work environment needs to be changed, or they're not suited to work. They're not suited to driving. These sorts of very important assessment and management questions. So to pharmacotherapy. So like migraine, we can go to the prophylactics for a chronic condition. So amitriptyline is often used. Beware, of course, sedation. Works in about half of people to settle things. Propranolol or in combination with NDEP, although I tend not to. I tend to use these agents in isolation. Propranolol actually would often be my first agent if they haven't got asthma. That can gain a really good response rate for post-traumatic headache. The other medications are not well studied, the other prophylactics. Triptans and simple analgesia can be used. The literature tells us that Panadol in combination with Nurofen is more effective for terminating migraine, and higher dose aspirin. So a couple of Dispirin is good. You get the fluid, it gets absorbed quickly, and it's high dose. Obviously aware of gastritis. CGRP antagonists. So these are very targeted, tailored modern medicine medical therapies to the CGRP receptor along the trigeminal nerve complex. Great occipital neuralgia we've talked about with nerve blocks, very important. But then Botox is a common go-to, and this is a really good treatment. It's our best treatment, it would seem, for chronic migraine and post-traumatic headache. Beware the analgesia overuse. So too much codeine, too much Panadol, too much triptan. So if you take triptan more than a couple of times a week, it may lead to analgesic headache. What are the barriers to recovery? Well, overly aggressive treatment, analgesia overuse, or comorbidity in patients can be problematic for getting them returned to care and getting them true recovery. sometimes there's litigation or compensation issues in workers' comp, for example. The repeat concussed patient, you know, they are impaired. So it's always so important to recognise that they may not be able to make sensible decisions for themselves, and they may say they feel fine, but very often they're withdrawn, there's abnormal behaviour, they're down, that maybe they're suicidal, they may have true cognitive impairment but not come forth with it. Female gender increased risk. Glasgow coma scales, I don't tend to use these, I have to admit, unless I'm working in an acute hospital setting, but of course, I guess if they were somnolent or, you know, you'd be concerned. Patients with complicated TBI, so an intracranial hematoma or depressed skull fracture. So very often patients get slipped through the cracks of the TBI rehabilitative services. So their CT might be normal cerebrally, but they've had a depressed skull fracture, and you can bet that there is some degree of gliosis and scarring, but they haven't had their MRI and they haven't been assessed or put through the rehabilitation services. And their symptoms may be delayed at 1, 2, 3 months. So the families struggle. So do a really good service. You can pick out those patients and get them into TBI clinics. Premorbid physical limitations are an issue. So managing the whole patient well, of course. Life stress, COVID. It's been good in some ways, hasn't it, with telehealth, but not so good in others. Remember the functional disorder overlap. Remember that patients with conversion disorder often actually do have migraine or do have post-concussion. So we need to manage both well. All right, prolonged symptoms. So there are some patients with these really long symptoms, more than a year after a concussion, after a simple concussion. Treating the patient emotionally and just being with them through chronic care is a good start. The factors to all of that remain unclear, but at least you can be there to aid and assess and keep thinking about their management. So we'll start to conclude, and then we'll have some time for questions. So here are my headache pearls. So post-concussion syndrome is a common but often complex constellation, and so you might consider getting specialist care. Could be sports physician, could be neurologist, neurosurgeon, some appropriate careful advice, and there are neurophysiotherapists, of course, and neuro-occupational therapists, so consider very subspecialist care. Women, children and older patients are appearing to be more susceptible. Remember, with kids, kids are kids until they're 25. The brain is developing right up until that point as far as the frontal executive functioning. So being very cautious about their care is important. The severity of brain injury does not clearly correlate with the risk of post-concussion syndrome, nor the prognosis overall. So a minor hit can be serious. Theories of structural and biochemical brain injury are of great interest, and there's animal models showing changes of neuroinflammation and other effects. Head trauma pearls in general. So your patient who used to be a footy player, now they're 60 and they've got memory impairment, or the patient who's 25, they've had 15 years of contact collision environment, and now their family's worried, but they're not worried. So inside matters. Always take it seriously. Decline matters. Have they got a 6, 12, 18, 24-month history of decline? You'd start to really attune to maybe there's something more. Always treat anything that you can, anything reversible in cognitive neurology. And the research is really important. We always push our own sort of research, but in this circumstance, I actually do think that this issue is a unique, special, important challenge for Australia at current, because no one can tell you how many patients are out there with head trauma related cognitive impairment or behavioural or mood disturbance. And so finding those answers is pivotal going forward. So I hope I've enlisted your passion into this topic, like all of these lovely people as part of our team. I'm very happy to answer questions either now or at a later date. You'll find my email online or through the MARTA, of course, or through my clinic at Harbour Neurology Group. And yeah, happy to go with some questions now. So thank you very much for your interest.
Well, thank you, Rowena. That was a very fascinating talk, and you've got an extremely talented, very well qualified team around you. There is a question on the chat forum that's came up early on in the talk there from Dr. Holiday, Louise Holiday. Sorry, I'm just trying to bring that up again. She asked, what was the screening tool that you use for your screening?
So for, yeah, I don't use, I'm going to have to admit here, I don't use SCAT5. So I prefer my own clinical judgment and say, oh, there's something wrong or not. But that SCAT5 would be the most widely assessment kind of concussion screening tool. But I do use this post-concussion symptom scale, partly because, you know, you're running through symptoms and you're partly educating your patient at the time about the different symptoms that could be there. And you're just getting another sense in a different way of how they are. But I think my own belief is we need to work on better screening tools. In the top levels, there will I believe, be a role for video analysis. You can tell a concussion and you can make that machine learning. So we're at Macquarie, we're really keen to pursue that line of research with new biomarker work for concussion. And then, but we don't have video analysis. We're looking at really quick neuropsychology screening assessments that maybe can be performed in under 5 minutes. We've already cut our neuropsychology testing down to 90 minutes, screening for CTE type syndromes. But yeah, we're hoping to have a more widely released app that could be used and longitudinally, so the patient can have it as an app online and re-engage and reassess. There are some screening tools for concussion, or more, at least checking in and saying, I've had a concussion on this date. There are some apps that are being developed. So maybe we can all work together to find some better screening answers.
Sorry, I know there's other questions, but just for the GPs in the audience or the joining us, is there one that's quick, reliable, and that can be downloaded quickly and utilised that you would recommend?
Yep. So I think for concussion, SCAT5. So that's good. That's got the best evidence. How
long does that take to do?
Yeah, it takes about 10 minutes. And if you're more familiar with it, it's better. But I think look, day to day, things are very rushed. You're probably not going to be able to have time for a SCAT5. So I think you could do the post-concussion symptom scale. That's a faster test.
Can these be done by practice nurses, or it has to be done by a doctor?
Yep, very much practice nurses. So I've got it right behind me here, so I can show you. Can you see that all right? So it's very easy. It's just a graded, quick response on do you have mild, moderate, or no symptoms, severe symptoms for all of these listed symptoms here of noise sensitivity, irritability, sadness, nervousness, emotional. It's very easy to understand.
Okay, so that can be done in the waiting room.
Yes.
Very few doctors run on time, so. Okay.
Yeah.
Thank you. Now we've got some questions in the Q&A panel, so anyone who does have questions, just type them in there at the bottom of the screen. So George Quitner, MRI for every headache lasting longer than expected and unexplained?
Definitely. So look, the MRI, it's got so many good uses. So it tells you an awful lot, and you pick up incidental findings. You might find demyelination in your young female footy player. Headache, if it's pure migraine, the chances are you won't find anything. You'll probably find a normal brain, but at least you can talk to the patient and show them the scan and say, here's your brain. Isn't it cool? Isn't it interesting? Or you can say, oh, at the age of 50, oh, there's a couple of white matter changes emerging, which might be capillaries, or little narrowings of the capillaries that we all could get when we're getting older, or having risk factors for blood vessel disease. So you can sort of talk through and get a baseline on that patient. And sometimes you'll pick up gliosis in the frontal regions or frontotemporal regions, or you might even see some tiny microhemorrhages. So when I order an MRI, I would order a SWI study, SWI. I'd make sure that's done, and I'd make sure there's an MRA, because you assess the blood vessels. You consider an MRV for sometimes a venous thromboembolism can complicate head trauma. So especially if there's been something quite significant like a degree of subdural hematoma, you would screen for that, because obviously that could be life-threatening if it's along the sagittal vein. So I think, less CT, more MRI.
I think he emphasised the word every, but obviously if someone comes in with
okay. Oh yeah, so I'll address that. So
over headache and things, and obviously, and you need to be somewhat selective, but
Yeah. So if they've got a prolonged, so let's say they've got a headache more than a couple of weeks, you know, that'd be reasonable to do after a very simple concussion. I think it's reasoned that you could do it in any concussion. If it's classic migraine in your clinic, by the way, the literature would say, like, if there hasn't been head trauma and you've got just a migraine sufferer in front of you, you don't have to do MRI. So we do call it and say, well, no, it's not indicated if you look at the cost to society for classic migraine. But if there's head trauma, I'd be, you know, erring on the side of caution in a major metropolitan centre or in a major city and doing my MRI.
Okay, well, hopefully, George, that answers your question. If not, just type another question in the box there. From Sandra Wellington, well, it's just a very kind comment. Thank you. That was a great update. But she does have a question. Do all neurologists do post-concussion syndromes, or is this a subspecialty?
All neurologists do it. So it's been around as a subspecialty for a while. This sort of, well, there's headache, right, which overlaps concussion. TBI per se has not been with neurologists traditionally. It's been the neurosurgeons and the sports physicians, and you guys in general practice. So I'm keen and passionate that neurology should overlap this more. It is a condition of the brain. There's about, I think there's around 900 neurologists nationwide. There's only about 30 neurologists who kind of delve into the world of subspecialty cognitive neurology purely, although of course all neurologists are manage dementia well and manage headache well and concussion well. But I'm keen to pursue and push this subspecialty. Now is the time because we've got the wave of dementia. So we may as well be doing concussion well in a team approach with our other colleagues.
Are you engaging in any studies at the moment that you're looking for patients to scan their brains?
So we are pursuing that activity at Macquarie at current. So we've got about 100 partly characterised patients on our books. We're aiming to do 100 next year, well characterised, so fully according to our ethics through, which is for the SNAP CTE study. Concussion overlaps that. So I work with Paul Salmon and others at Macquarie University. We're doing acute concussion, we're doing post-concussion syndrome, but CTE is going to be a big focus of that. So any referrals through for clinical management, because our clinics will form the basis of our research. So we're welcoming any referrals so we can get to know our patients, and as funding and other resources are coming through, we'd like to be able to then offer them the research. So
GPs can make a referral to yourself, and yes. I think there's a few neurosurgeons at Macquarie who are involved, and
yes.
specifically to have an assessment and also potentially participate in the trial.
Definitely, and I'm very happy, especially if it's looking like someone who may be suitable for research, to consider a Medicare-only consultation. Yeah, that doesn't bother me. I just want to get people through the clinics, through to the research, and help them as much as I can.
Great. We've got a question here from Sue Coolshed, nephrologist. Where do you send the patients for the MRI? Is there an out-of-pocket cost? It can be a lot for some patients if you add on certain things to the MRI, like some of the things you may have added, MRV. It is a problem for patients in nephrology who have a lot of chronic illnesses and they're forever forking out money for their health care. So a valid point. Are there specific scanners that they can go to? If they join the study, are the MRIs subsidised or paid for? I mean, anything to help some of the patients that may be struggling and can't wait on a public.
Definitely. And part of our seminar next week, we've got a video with Steve Blocker-Roach and Jeff Fennick saying that they're not the ones we should be worried about, people who are driving buses after their rugby career, which is a lot of people. If, as far as subsidised MRI, the indication, as I'm sure you're aware, is headache unexplained with focal neurological deficits or features. So we can often talk to that, if they've got a prolonged headache, distant to the trauma, which is everyone by the time I see them, I can often seek a bog bill MRI at a lot of radiology centres, and I can facilitate, I'm very happy to facilitate urgent MRI through the public system as indicated. So I'll try to do everything I can. I don't have any funding for MRI research at this time. So despite this being such a major issue, despite us leading the work with CTE shown, no one, you know, and we will go through grants, but to get pilot studies up, it takes resources and funding. We haven't had that. We've scrounged it together. If anyone, you know, can possibly encourage the funding for our work, we're very open to that. We're trying to work with insurance and government on this to get Australia further forward. So I hope I can say in a year that yes, send them on. We'll pay for the MRI.
Thank you, Rowena. Just about concussion in sport. I know there was a flurry of activity a year or two ago about head injuries and certain codes, NRL in particular. But there's other codes, the Australian Rugby Union, AFL, netball, hockey. Do they all have separate committees, and do they have separate medical officers, and do they collaborate their research and their legislation? It seems like a bit of a mishmash at the moment. Is there any way that it's at a national level and it can be, you know, uniform and make it a little bit more easier? And then can it be fed down to grassroots club level rather than at the premiership level where you got medics on site and so forth?
Yeah.
Can you give a bit of insight into that?
Yeah, so it is really disjointed. I won't say which sports, but some sports have had injury across their desks, you know, cases, and there's pretty much an ignored response. It ranges from that through to we have good evolved protocols, but there's nothing coordinated and collaborated here. So we can do better. The AIS AMA protocols is probably the most collaborative we've seen on protocols. People are trying to get that effort together. Again, it's going to take funding and resources. One of the major aims of Mission TBI is to get a registry and get coordinated effort up. So that's great. It's in the pipeline. But one of the things we're calling for is a national repetitive head trauma initiative. So this would be educational. This would be evolving sideline assessments, feeding into the work with the question of chronic traumatic encephalopathy. So this does need a coordinated approach. It will probably require position statements from the colleges, and you know, I wonder if AMA could assist. You know, we all could have more roundtable on this and a coordinated approach. It may be because of the nature of sports and sporting interest, and that this is as much a financial decision for them as an ethical one, is to get the stick rather than the carrot. So one of my colleagues, Alexandra Boothie, is looking at the legal aspects. She's done a legal PhD, and so she's looking at global legal solutions or insurance solutions to say that this is the code of conduct, these are the guidelines. This is much like the drug authority, so ASADA and the World Drug Authority. You've got kind of World Head Trauma or World Concussion Authority saying you have to stick to these guidelines legislatively. So it may be that it's even that sort of big an issue.
Any other questions from our guests, participants? Maybe just one more from me out of interest, and maybe from some of the GPs. You mentioned concussion, no alcohol, no driving. Those two things very important for some people. How long? Or does it depend on the severity or ongoing symptoms? I mean, generally speaking.
Yeah, so generally speaking, for me, it'd be a month off. You know, I think it's not unreasonable to consider them much like your stroke patient, or you know, someone who's had syncope. Give them a month off both of those at least, and if they're not recovered, reconsider. And be aware of epileptic overlap. So another indication, of course, if you're concerned that they're having absences post-trauma, or any olfactory gustatory disturbance, or florid easy emotion and fear, for example, you know, I'd like to see them for any temporal lobe epilepsy assessments and EEGs. Okay,
and just remind everyone where your practice is.
Okay, thank you. So I'm at Harbour Neurology Group, which is in the heart of North Sydney. So a busy, bustling centre mostly during COVID. And I've also got rooms at Macquarie University at the MQ Health Clinic. And then I see patients at Marta. So I'm very happy to be there to assist in any way I can at those centres.
So people can, obviously we haven't got the details here, but can Google you and look you up and contact the hospitals. Well, thank you very much, Rowena. Now that I know that you're a national fencing representative, I better be careful around you and not get you in a bad mood while you're holding a tendon hammer. So it's a pleasure that you were able to educate us today. just for the participants, the next grand rounds will be in February the 13th. At that stage, hopefully having a talk from Dr. Paul, I think Dr. Kennedy, about the current state of cannabis use for chronic pain and other applications. But thank you, Dr. Mobbs, Rowena, and thank you for everyone for joining, and please enjoy your weekend, and I look forward to seeing you at some other stage in the future. Thank you very much, everyone. Thanks, Rowena.